Thank you, Shannon. Don't worry that we're running late. We'll just take it from your exercise time. So I want to take some time now for questions for our participants today. We have one already. Do you want to give her the microphone, or you want me to just repeat? Right.
My question's for Jennifer. And Jennifer, when you were talking about having your community health assessment on your website for input or anybody who's done this process, how are you getting the word out to the community that it's there so people will actually participate?
We're starting with our partners, letting them know it's there. And then we actually have a meeting coming up with our Public Health Advisory Council. We report up to our county commissioner, and it's his advisory group with quite a few organizations, so we'll let them know also. And slowly we're starting to get calls in about it, so that's what we're doing. Mm-hmm.
Other questions?
Sorry, Captain's chair.
Oh, I didn't turn it
on. It's on. I had a question for Teresa. You talked about the fact that you have to show a link between your plan and the state plan. Now, I don't know where our state plan is or how far out that is. I presume that if our plan is submitted before that, that wouldn't be a consideration?
I presume the same thing, but of course the definitive word would be the FAB board and whether or not they approve the application for accreditation. But you know, this is reality-based work, and they understand that. It's also about a process of improvement. So I think you don't link to something that doesn't exist. But documenting what does exist is important. Mm-hmm.
I'm Mike Messinger, and I'm with the State Health Department. And there is a state plan, and it is on our website, and you can link to it at dshs.state.tx.us. And it is, I believe it's on the front page, but you can navigate it from there. And it's also on the Health and Human Services website because it's part of the Health and Human Services strategic plan. We are one of the 4 components of that plan.
What's it called,
I believe it's the strategic health plan.
Thank you.
A question, is it an agency plan or a system plan, meaning partners?
It's more of an agency plan. Okay. There are 5 agencies included in that plan, but it is designed for each agency. So.
Thank you.
This is your opportunity. These people have been through it.
A question for Jennifer. On your priorities, you listed infrastructure. Could you say just a little more about what you mean?
Really, we found that we have a lot of existing improvement plans and a lot of existing resources that are disconnected. And so we just want to work toward pulling those all together and strengthening our infrastructure so that we can address them, have more partnerships for funding so that we don't have 5 applications from Dallas asking for the same kind of funds. So things of that nature. Yeah.
Jennifer, you're on again. You've brought up a really important issue. I'm thinking of sometimes it seems like a 9-headed monster trying to get everybody coordinated because people don't know what everybody else is doing. So could you address really how you truly pulled in those partners so that you got that working across stakeholders kind of effort? So it's more of a, so you're not having duplication of services or duplication of your applications and so forth.
Right. Showing how it's important to them was the number one thing. So we emphasized to the hospitals, we're really trying to stick to these IRS requirements, but we also gave a disclaimer that if it doesn't meet them, we're not liable for your $50,000 penalty. So just showing how it was important to them was the number one thing, and that got them to the meetings.
But I'm also talking about other nonprofits or other agencies that do public health types of work, not just the hospitals, because I know they have a vested interest. They don't want a $50,000 penalty. I'm talking about your other agencies.
Okay, Larissa will answer that.
For Houston, I think what we did when we went to speak to community partners is we really said, you have a vested interest in this, and it's turning the public health system from being really siloed to a true system. And then the other piece I would go around and say is that accreditation forces us to be accountable to you as a community organization. So if we're not doing what we say we're going to do through the health assessment and the plan and the strategic plan, you have the absolute right as a community-based organization to call us on it. And to work with us to meet those requirements, because as FAB goes, you're supposed to provide process updates annually, and I think at the end of the 5 years of accreditation. So making them feel like, well, now we can actually go to the health department and say, hey, you're not doing your job, and you said you were going to do this. And I think that is empowering for them. And so that's what we used in Houston.
One of the things we had also was the opportunity, because we actually fund most of these social service nonprofits agencies, is to incentivize them as part of their grants or funding, was to be able to help identify the things they were going to do for that. Particularly, there's an organization called One Voice, which is sort of the umbrella for many of the social service agencies. And what they want out of health departments and out of funding also is the ability to be able to say, we're part of the healthcare network. And so utilizing those mechanisms, we've been able to incentivize them to participate in the process and help guide us in this process. So when we look at things other than just health, things such as basic needs and built environment and healthy foods, those kinds of things, they feel that they're at the table equal with the Setons and the hospital things as well.
My question is related to the community engagement part. Did you only engage with organizations representing groups, or did you actually do focus groups directly with people from the community?
We did all of the above. We divided the county up into the 4 precincts of Travis County. Each precinct, of course, has a commissioner. Austin sits in each of those communities. So we conducted 4 community forums, one in each of those precincts, allowing the citizens of the city, as well as citizens of the county outside of the city in that precinct, to come and participate. At a series of questions that we vetted through the community to get their feedback, and those formed the part of the qualitative report that came out of the assessment. So yes, we used forums in which we talked with citizens one-on-one. We used focus groups, which we talked to key priority areas that I mentioned. We do the key informant interviews that we talked about with the elected officials and the like. And then, of course, we did the agencies and others as well. So we did a component of all of those.
And your modified map, was that written somewhere where you got to modify and how you got to do it quicker?
I'm going to let our expert respond to that one.
Well, we chose to follow the MAP process, and in that decision-making process, we looked at all of the frameworks that were presented earlier today, and so we kind of merged some components from things from ACHI, from MAP, from pre-seed, proceed, but we chose to label it as modified. It gives us a little bit more flexibility and freedom in our approach, but also one specific assessment out of the 4 assessments from MAP is a local public health system assessment, and we had discussions around that. We didn't do a formal assessment in this allotted time period, but we plan to do it next iteration. So a lot of, actually, that's a great question. A lot of the demonstration sites for the NACCHO accreditation preparation CHA-CHIP 12 local health department sites, they also term their approach as a modified MAP approach.
Thank you. I just want to comment that the way you describe using MAP is the way MAP, in fact, is designed to be used. So it's intended to be a flexible framework, and you start where you are and utilize the pieces that are important and relevant, assuming that you've bought into the underlying assumptions of the MAP process. I think that's where the real paradigm shift of MAP occurs, is in the upfront, buying into the framework, the idea that it's a participatory process, that it's not the agency knows everything and must do everything, but everyone has something to contribute. But from there, the flexibility, the ability to modify is part of what I think is attractive about MAP.
And that MAP packet is on the NACCHO website, and you can download the guide, the tools. You can use it as you need it. So it's all there and available.
Yeah, I just wanted to dispel any thought that MAP must be done exactly as you see it on the website. So don't apologize for modification. Embrace it.
Any other questions? No? Okay, well, let me spend. Do you have anything burning, new information they feel compelled to share with everybody? Something, you learned in this last exercise that hasn't come up previously that you feel is valuable for everybody? Yes.
So one of the things, because I do see some folks that may have stayed in here versus folks that were in there, one of the things our group came up with that when we were talking about what stage they were in, we were looking at the first 4 stages and what are some of the issues for being where they are or not being where they are. It kind of boiled down to 2 things: staff, needing funding, needing a dedicated staff person to do accreditation if you're going to look at that process. But then the other thing is that you needed availability of qualified staff for that area. So you may have the funding, but you may not have the qualified staff in the area. So I guess I wondered what anybody in we've got Houston and Dallas still here, Fort Bend, what y'all might think about what you're doing, because it's competing issues and staff.
Comments?
Larissa, I'll put you on the...
Houston is actually very fortunate to have funding from the CDC to support our accreditation and quality improvement initiatives. But even though you have the funding and the staff, it's still not enough. You still really do have to leverage your resources in your health department. And so what we did is we created an accreditation work group made up of different people across the department at different levels, with the idea of they being kind of our on-the-ground troopers to get out there and collect the information and to move things forward. And so you really have to leverage what you do have. Yes, we're fortunate to have funding. Yes, we're fortunate to have staff. But even still, that's still not enough to move things forward. So you do have to leverage who you have.
How about you, Jen? As far as leveraging your resources, if you can tap local companies, they actually usually have funds earmarked for helping out with the community, and as a health department, they'd probably be willing to give those funds. Or, of course, if there are certain steps in the process where your hospitals can help, like our hospital actually hosted one of the focus groups, that's another good way.
Okay, what about y'all's area? staff or resource-wise, or what have y'all? What we found is that many people did not have a dedicated coordinator yet.
Right. Well, in our health department, we have a fairly good-sized county now. We're over 600,000 in population, but the health department itself hasn't really kept pace with what's going on in the community. We have 150 staff, but 80 or 90 of those are EMS, so take those off the top, and you've got the rest of the health department. And so the way we've looked at it so far is, yeah, I'm the accreditation coordinator, and that's on top of everything else that I have to do as well. So it's not dedicated. I mean, yes, I'm dedicated to the process, but everything else that comes up ahead of it, like, you know, the crises of West Nile virus, or this last year, 1115 waiver, even though we said we weren't going to talk about it. But so for me, it's a case, it's something that I think is really important, but to go to the commissioner's court and say, I need another person to do this is not going to happen. So we were really excited last year, was it last year? Earlier this year, when DSHS looked like they were going to pass out that additional money that they had in the, I guess it was the same money that OOO comes from and everything. They were going to give us some money there. We all applied and thought this was going to be perhaps the answer. And it turned out they didn't have the money afterwards. So I think that's the kind of thing we're going to have to look for to get someone or some agency or some group that can commit themselves 100% to this and not be waylaid by the other things. I don't mind leading it in my health department in the terms of kind of being the champion for it, but in terms of having the dedicated time, it's not, I don't think it's going to happen very easily unless you can guarantee that next year there'll be no 1115 waiver, no West Nile virus, no pandemic or anything else. So I mean, I'm sure that's pretty true for a lot of groups and trying to fight on this right now. So.
Okay. Well, instead of me summing up this session, I think I'll just turn it over to Bobby to tell us about next steps.